So this is Tande Gatlamini today on this day, July 25th, 9:25 a.m. in Mbabane, Swatini, conducting an interview for the Global Oral History of PEPFAR in Eswatini. So to begin with, Doc, could you please just start by introducing yourself, who you are, your family, where you come from, where you were born, and your academic credentials?
No, thank you. My name is Ruben Sahabo. I was born in Burundi and I'm a medical doctor, graduated at St. Petersburg Government Medical Academy in Russia. And my career, I can say that my career was mainly, my career started in Rwanda. I worked with the Ministry of Health. Then from the Ministry of Health, I joined USAID Rwanda. Before I was hired by ICAP in 2005. So I have now 20 years with ICAP.
Okay, thank you so much for that background. So when you were in Rwanda with USAID, can you just explain what organization, or you're working for USAID, so what capacity and the type of role that you were doing when you were with Rwanda USAID?
Oh, with USAID, I was working as HIV community advisor. And I can say that I was lucky because PEPFAR started when I was already with USAID Rwanda. And maybe I forgot to mention that I worked about 6 years with ICAP Rwanda before joining ICAP Eswatini at the end of 2011.
Okay, so could you explain the role of being HIV community advisor? What did it entail? What was your day-to-day duties in that position?
Yeah, as I mentioned, I joined USAID in 2003, and I was working with the HIV program, advising, the team, planning, working, playing the role of liaison with the government in relation to planning for HIV response, trying to design, working together with the other partners in the government programs to design program, because that, so when the country was getting different support from, PEPFAR, from Global Fund, and from World Bank, and we were working closely with other stakeholders and government institutions involved in the HIV response to design and implement a program for HIV response.
I see. So fast forward to 2011, you come to, so when did you join ICAP in Rwanda?
I joined ICAP in Rwanda exactly in the mid-2005.
Mid-2005. And then what capacity were you performing in that organization when you joined initially?
Yeah, I was hired as a country director, the first country director for ICAP program in Rwanda.
I see. And that I can imagine ICAP coming to Rwanda had the role of wanting to implement HIV programs, right? Because that was soon after PEPFAR was available, and ICAP had formed to go globally and be part of the HIV response. So if you recall, what was I know you had been in the country for about maybe 4 or 5 years before you took up that role as ICAP country director, but explain, what were some of the duties you had to do to set up ICAP, from scratch, because it was not existing before. As you said, you were the first country director. So I reckon that meant establishing the organization from scratch in Rwanda.
No, thank you. Of course, the first duty was like to establish the office. Make sure that we have a team, operation technical team that can, run the program. And also, other duty was like to work closely with the government institutions, government counterparts, colleagues, to identify priorities. Because ICAP in that period, ICAP was one of the leading HIV care treatment partner. So the duty was to identify the priorities and agree with the government how we prioritize the resources, developing guidelines, tools, conducting trainings, and putting in place, system for data collection and analysis, to inform, further plannings and the monitoring of the program.
I see. So I just want to ask a bit of more background information about your training and leading into you working in HIV. Was that your focus, non-communicable diseases, whilst you were in training for medical training? How did you come to work in HIV?
Yeah, as I mentioned, yes, we were supporting the government, Rwanda, but we need, first of all, to make sure that we establish, system to make our partnership to work. Put in place structures that will help, to bring, different pieces together, to make sure that stakeholders, they work as one team. I remember one of the success story for Rwanda at that time was the establishment of the steering committee to make sure that you have multidisciplinary, not only doctors, running the problem, responding to the problem of HIV, but make sure that nurses, other programmers, data, staff are involved in that process of planning, defining priorities, designing interventions, and make sure that at district level, at health facility level, also we have teams that are, being capacitated to make sure that, they develop their skills and the knowledge, to participate in the response of, HIV epidemic.
I see. So how do you now move from Rwanda to Eswatini? If you can just explain, was it the position you applied, or based on your experience to set up ICAP in Rwanda, that it was an automatic decision that you transitioned to Eswatini?
I can say it was an automatic decision. There was a need of account director in Eswatini, ICAP Eswatini, because my counterpart that time was exiting. So I got interested and applied, and I was, trusted, to get this position and continue, the support as, ICAP member.
It seems to me that you're involved in HIV already in the early stages, or even prior to the arrival of ARV, to manage HIV. Could you recall how was the situation back then? I mean, in the different African countries that you have worked in, how was the scourge of HIV? And being a medical doctor, how was the situation as far as you can recall from back then?
No, thank you for the question. It's very interesting, to recall that experience, because first of all, there was not much support, HIV. Yes, you could have like one NGO here supporting, working with the government to, to provide the services or to build the capacity in health service provision in relation to HIV. But you could see that people were, or organization were working, in, not coordinated manner. And that was, maybe was a challenge, to the distribution of resources to make sure that services can be provided in a equitable manner across regions, across districts, or health clinics. So one of the achievement of PEPFAR was to help the country to bring together those pieces and to put, structures, system like steering committee to make sure that partners, they can share what they are doing in given geographic areas on technical domain, so that the country can avoid duplication and the waste of resources. I can say that the establishment of those structures like technical working groups, steering committee, task forces was a foundation for better coordination of available resources to maximize impact of the support.
Mm-hmm. So let's now dive deep into your experience in Rwanda. Mm-hmm. I believe you've worked in Cote d'Ivoire as well.
Yeah, I didn't work in Cote d'Ivoire, but I supported the establishment of the program in Cote d'Ivoire.
Remotely from Rwanda.
And I was also traveling to Cote d'Ivoire, and also in DRC.
And DRC,
yeah. And the Burundi, most recently in 2019.
I see.
Yeah. And then mainly it was like scoping, and they also supported the startup of the program, including identifying priorities, but also recruitment of the first team to start the program in those countries.
I see that you seem to have expertise to be able to go into virgin land and establish the relationship, the connection with government, and all of that. So for somebody who is an upcoming medical doctor who wants to work in public health, and they might be in your position to go in a nation they've never been before, what would you say would be the lessons or the learnings in terms of this is ABCD that you need to do as a foundational intervention to be able to establish, relationships, the government to trust you and set up an office? What would those kind of learnings be?
I think first of all, you need to love, or to like what you are doing. You need the passion for it. And the second, listen, observe. As I mentioned, the core principle is like partnership. You listen, and you will observe. You don't dictate. When you go to host the countries, it's better because there are people who knows the context, the cultural context, the needs, and it's very important that you learn first before even you can advise what can be done, and this can offer better ground of working together when you listen to your counterparts you find in the host countries. It can facilitate the work or the collaboration as you move forward.
I see. So, do you know the reason behind ICAP coming to Rwanda specifically? I don't know in terms of order, if it was the first country in Eastern Africa, or was it a bunch of countries in Eastern Africa and Rwanda was one, or was it the first one? Can you just tell us the history, how ICAP came into Rwanda, or why it chose Rwanda?
I think there was funding opportunities that was targeting some countries, including Rwanda. It was Rwanda and a few countries I remember. There was Kenya, there was Ethiopia, there was South Africa.
The first 15.
Yeah, Rwanda was among the first 15.
I see.
And Rwanda also was one of the so-called track one targeted countries.
I see.
Yeah. So ICAP applied for that funding opportunities and won, and this is how they came to Rwanda.
So when you came to Rwanda to set up office, could you remember what the situation of HIV was back then?
I was privileged because I came to ICAP Rwanda from the Ministry of Health, USAID.
Okay.
So I was not, naive. I can say that yes, services were there, but not many people were accessing those services, like testing, like even other laboratory care treatment, or other laboratory tests like CD4, viral load for those who are already in treatment. So I cannot say that things were fine. There was a lot of gaps because I can imagine those who were accessing services maybe were those who are in big centers like Kigali, and then when maybe you can find some testing site, and then the decentralization of care treatment services was not yet optimized. So this was the situation, and PEPFAR came and supported the scale up, the scale up of those services to more remote areas in the countries. Mm-hmm. Yeah.
So can you tell us a painful moment in the country's history when you're involved in the response to HIV/AIDS in Rwanda, or even as well as like a time when care was beginning to rapidly expand and there was hope, because we're coming from HIV being almost a terminal disease. Mm-hmm. So then you're involved in the earlier stages where there's treatment and there's hope, So if you can just contrast those kind of experiences from being, hopeless, and then there's treatment through PEPFAR support, and then, there's hope with people. Can you recall some of the instances?
Yeah, the most painful, time is, you see when someone is tested positive, and testing positive, it's like already a death sentence, because before PEPFAR, it was not sure that the person who has been tested positive will access to treatment. And you could see that some, opportunistic infections were too much. They have this zonal, the infections, they have the TB. So, it was painful that, someone knows the status but cannot access the right services. So PEPFAR and other program like a Global Fund, they came like rescue, to change that situation. When people living with HIV started accessing treatment, you could see like the improvement, in life. You see someone is productive as any other people. You see like hope coming in the family. Otherwise, like one person in the family is tested positive, was even afraid to encourage or to bring either the partner or children to test, because they say, oh, if they test positive, what is the solution? So that fear, was like very impacting, the society and the families, because services were not there. With PEPFAR, you could see that hope increasing was increasing over time because people can access services, and the family can access, services, and bring hope.
So could you recall what was your startup grant from PEPFAR when you were in Rwanda?
And it was in early 2000. Yeah. As I mentioned, and around 2004, this were like maybe the first support came to Rwanda with PEPFAR.
Can you recall how much the grant was then?
I cannot say,
Yeah.
but
It's okay.
yeah.
Okay. So can you
But I
explain-
can say that I think it was around 50 million,
50 million
US dollars. Yeah.
Okay. So can you explain to somebody who's not worked through PEPFAR funding, how does a normal year of funding cycle goes? So if you start from April to April, so what sets off the stage to say, okay, now we have the PEPFAR funding. This is how the year goes, until we finish, or a whole cycle, if it's 5 years, I don't know. Just explain the grant cycle for PEPFAR, what is entailed in it.
I remember initially it was like April to March. Then we moved to the cycle of October to September. But what is important is the planning and funding was on a yearly basis.
Okay.
So the country partners had the opportunity to sit as stakeholders with the government institution and a plan every year. So you can reflect and see what you were able to achieve, what are the gap, remaining, how the program evolve, and you can continue adapting strategies to the priorities identified together with the government institutions.
Okay, so now you have the office, you have the resources. So how does PEPFAR help in any way for setting up staff complement? Are there advisors coming from PEPFAR to help you set up office? How do you liaise with the PEPFAR in establishing the office and to get the program running?
Yeah, I can say one of area of assessing priorities of the human resources. Of course, in Rwanda, like in Eswatini, the response was government-led, the host government-led. So you sit together to see what is existing, which positions or which skills are available at which level, and how PEPFAR can come and supplement to fill the gaps in the human resources to optimize the response.
And then from then on, defining the priorities, you sit with PEPFAR or you sit with the government, or it's everybody?
Now, this is one of, I can say, success stories that, even other programs in other areas they can learn from. It's that, yes, we're sitting as PEPFAR implementing partners, U.S. government agencies like CDC, because ICAP was funded by CDC, and we sit together with the government. Remember, I mentioned about established steering committee, and the steering committee, when members selected from different institutions, from different even ministries, and the members of the steering committee will sit together with implementing partners and the donors or US government agencies, and they plan together.
And then can you explain to me your relationship with the government. Did you have a focal person? Did you set up an office within the Ministry of Health or government? Did you second staff that were positioned within government? I mean, how did you make sure that your work with the government was effective?
First of all, from my experience, the establishment of the office, I can say that, that there was a strong support by the government to facilitate different processes. For example, as I mentioned, yes, the response is led by the government. And in the process of needed assessment, you may find that, we are lacking these skills. How can we get them? So there were, some staff that were hired from outside. And I also remember we needed always, to work with ICAP headquarters, to make sure that we get technical and managerial support we need, to streamline, the support in the countries. So the government will facilitate like getting visa, getting work permit for the staff hired from outside, from outside the country. And as you asked about human resources, yes, we had some position filled within the government institution from central level to health facilities to make sure that we fill those, the gap in skills, such as data officers, mentors, clinical mentors, laboratory staff, to make sure that the package is provided with skilled staff. So we make sure that we fill those gaps, but with a plan for continuous absorption of different position by the government over time as the resources of domestic resources are available. So this is how we worked together with the government.
So I'd like to hear a bit more information about how did you begin now the scaling, the rapid rollout of treatment in Rwanda? I mean, we'll have more or less the same kind of questions for Eswatini, but starting from there, because I think your experience in Rwanda helped you to replicate or even adapt some of the lessons that you had from Rwanda.
Yeah, this is a good question, because I remember when I started working, in this field, especially with ICAP, you will find like you have like more than 3 implementing partners in the same facility, in the same in the same district. Maybe some duplications, or one partner that doesn't know what the other is doing, and this is what not only was a coordination challenge, but also a risk of wasting resources. One, and the second, also because there are many people coming to the same facility, maybe with the same agenda, it's also a burden to the staff that are overwhelmed by a long queue for patients waiting for services. I remember that the first contribution of PEPFAR was to address that challenges, make sure that activities supported by implementing partners are coordinated. This went like through the steering committee. It was decided that, let's see, we need maybe one partner, one implementing partner leading maybe the support in given technical area in that district. And it's not, it was not encouraged to have multiple partners supporting one facilities. So this was like the first, maybe coordination and support that or model that was brought to the table and discussed with the government, counterpart, and making sure that partners are better coordinated. You don't have duplication in the facilities, district, even at central level. So this was one of the I can say the success story. The second success story I can mention was like the way the data was collected and reported. You could find that each partner has, its system. They collect this, different way, they report in different way, but with the government, we discussed how, the data collection and the reporting can use the same similar system. And this was also helpful for the supported institution, the supported government, to better plan and respond to the epidemic.
Could you please point out like one program, strategy, or intervention that shaped the response in Rwanda? I mean, I know you could have NIMAT, this, that, there's been a lot of different approaches. What would you say were some of the key programs that you implemented in Rwanda as part of PEPFAR funding?
Mm-hmm. Okay. In Rwanda, of course, we were supporting like testing, PMTCT, and HIV care treatment. Mm-hmm. And one of the innovation was like the response or the support in relation to services provision is not just a matter of one category of professionals. We agreed on the multidisciplinary approach. Means that we, at the facility level, we need to have a multidisciplinary team involved in the HIV service provision. They plan together, they review the program together, because I mentioned that one of the achievements was like supporting, putting in place data system. And then the response started to be driven by data. So the multidisciplinary team at facility level, at the district level, will meet, sit, and review their data. Because I remember another maybe lesson learned in the beginning, you will bring like the data to present to the team that, oh, these are the gaps, this is your data. Then they would say, no, this is not our data. So
because it looks bad?
Because it looked bad. And over time, we could feel that there is a strong ownership of their data. They don't wait when you come to say, hey, did you see your data, how it looks?
How was that changed? How was that changed, reached?
Yeah, the change reached by, especially from like mentorship. Mentorship also was driven by data. When you go, when the team goes, the mentorship team goes to the facility, they say, let's pull out your data first. And you prioritize the mentorship topics according to what you are seeing happening in the facility there. So that this is at facility level, but also at the district level, you have like how they call it, the district team. So there were like some review meetings, regular review meetings. It can be by monthly within the district or quarterly, where you bring different districts in the region. They sit together, they review data. So the data stimulated a kind of positive competition. They say, hey, I'm looking bad. The next time I have to look better than this.
Have the competition.
Yeah. Mm-hmm. So this is how the culture the culture was developed. The culture of data-driven planning, data-driven response. Another thing that I can say that contributed to developing that culture is the expectation from the donor, but also from the government, because always government want to know, want to link the resources, to the accountability. Are you achieving the targets? Are you achieving the objective? We are assigned, to achieve. So that that spirit of, insisting on accountability also helped, to make sure, I need to monitor my implementation and see if I'm on the right path in relation to achieving my targets.
I see. So I reckon you are not doing this by yourself. As ICAP, you had partners locally. Can we talk about who those partners were when you were in Rwanda, and how you identified them and their role?
First of all, partners included like the HIV programs at central level, but also the district, because each district was overseeing the planning and implementation of the response in their respective district. And we had health facilities. And I want to mention that at the health facility level, we have like faith-based facilities, faith-based health facilities. Because these facilities belong...
faith-based.
They're faith-based.
Okay. I was going to ask about that, that your partners
yeah.
faith-based.
So the faith-based organization were also partners. And another strong partners was like the Association of People Living with HIV/AIDS. And I can confidently mention that this was one of the success story of Rwanda, because they helped people living with HIV to organize themselves in associations, and they received the support from the government, subvention from the government to have clear structures, leadership structures, and make sure that they are always engaged. They're not like a passive recipient, but they are part of the active response in the country. Yeah.
I see. So one of the concerns for PEPFAR, as you were engaging different human resources and assessing the gaps that were there in terms of technical expertise, so there was definitely that aspect of strengthening the healthcare, the health workforce. So can you talk about those efforts in Rwanda? Were there any streamlined, established efforts that ICAP did to make sure that the capacity of the healthcare workers is done?
So, as I mentioned, capacity building involved trainings, but also, the support was to develop training materials and the guidelines, and staff are trained on those guidelines to make sure that services are standardized in the countries. And also the mentorship component was very important. Yes, you train, providers or staff go back to their institution. There should be a follow-up, and they see if what they have been trained on are being applied, and they also continue to fix gaps as you do assessment and see how guidelines are being applied. Another aspect I want to mention here is the support to the supply chain. You may have skilled staff, but if you don't have drugs, if you don't have reagents in the lab, supplies, services may be interrupted. The mentorship, the planning also address those aspects important in health system to make sure that all conditions are there to have continuity of services. So ICAP, these are areas where ICAP were supporting, but together with other partners, because as I mentioned, in the effort of coordinating the response, implementing partners were assigned different districts. When they say, okay, ICAP, you are leading in this district, yes, there may be other implementing partners maybe providing other services like at community level or in other areas, but ICAP will be leading in this district, and you are responsible to support the district, the health district team, to make sure that what is happening is better coordinated, and you share information, you share what you have found as a gap, to see if you can synergize your effort in supporting the district to address those gaps.
How about capacity building for nurses, medical teams? Because HIV was new. There could have been doctors and nurses, but the protocols and for treatment of HIV, treatment guidelines, adapting and all of that. I mean, did you have to do that to build capacity and increase expertise of those medical teams?
You remember that the entry point was does the country has guidelines?
Yeah.
Are guidelines standardized? If I'm in this region or in this district, am I receiving the services, the same package of services, the same way? The first thing that was considered was, as I mentioned, HIV service provision is not a matter only of medical doctors. We need multidisciplinary team, and the guidelines were developed and shaped the way that you will find the doctors, nurses, sitting in the same room, being trained together. And this is, bring a very significant, positive change in the way the teams work at the central level, as well as at the district and the health facilities, because you have medical doctors, nurses, psychosocial support officers, you have even other counselors. So this helped to develop what I called the multidisciplinary team for HIV services provision. So the guidelines were developed, the training will happen in the integrated manner, and so the mentorship was easy because things were standardized in the country.
So I want us to talk about your brief stint with Cote d'Ivoire and DRC. You did mention that you were providing support traveling there. So, can we just talk a little bit about that? How long did that last? And when you are going there, what would be your engagements to provide that support in those countries?
Yeah, I want to say that my support was to initiate the program, scoping, see where the country is, what ICAP can bring to the country, talk with the Ministry of Health colleagues, and agree on the priorities. Maybe also have a picture of who is there and what other partners are supporting, how ICAP can bring added value to what others are are doing, and also maybe try to, to share in a humble way, to share maybe what worked like elsewhere that can be replicated in that countries, because now the world is network. We don't have to reinvent wheel every time. So it was important to learn what is happening there. I can also maybe bring to Rwanda, but also share how things are maybe being done in Rwanda, and see, is there something that can be replicated or learned from from Rwanda and applied in those countries, because another lesson I learned in Rwanda is the importance of the governance, the leadership, the country vision, where they want to take the program, and it's very important. The country may have have skills available, but if the leadership is not engaged, doesn't own the program, it may not produce the result expected from the program. So those are when that some lesson learned can share how this country is doing, addressing this gap or this issue. What can we learn from there, and how we can continue to exchange, our experience. And then we're lucky with our leadership at a global level. There were also some initiative of bringing together different country team to make sure that we can exchange the lesson learned, best practices. Yeah.
So coming to Cote d'Ivoire and ICAP establishing its presence there, they were coming from war. So there was a peace treaty. So you're coming from a war-torn zone that is, country that is security-wise is destabilized and all of that. So I can imagine that was a unique experience for you. Can you talk about that? Like, how do you come in and get the buy-in, and who are the brokers for ICAP to be able to access the government and have them on the table to ask to establish the organization?
No, thank you, Tandika. I think Rwanda was in a good position to share this is why I talked about the importance of leadership. You remember, Rwanda was coming from a very tragic, situation of genocide against Tutsi. When PEPFAR came, it was like just maybe few, less than a decade after, coming from that, situation where everything, including the health system, was collapsed, and no one could, believe that, a country that faced that, tragedy can move on and pick up and have a successful, program that other countries can learn from. So, as I mentioned, going to Cote d'Ivoire in 2008, 2009, from Rwanda, I could feel comfortable that I can share and encourage Cote d'Ivoire that they can, make difference, because what they faced was not even, at the magnitude what Rwanda faced with the genocide.
I see.
Yeah.
And then DRC, politically, at what state was it at? Was it also coming out of a war when ICAP was starting to establish itself in DRC?
It was like, 2010, 2009. I think, DRC has been also been facing some, instability. But, as I mentioned, also they they have a potential. They have the potential to, to make difference with the response. Yeah.
Okay, fast forward to Eswatini. Finally, we are coming home.
Oh, we're coming home.
Yeah, so when you come to Eswatini 2011, you said, right?
Yeah, in December 2011.
December.
2011.
Seems like you remember that vividly.
Yeah.
So you come to Eswatini. So what's the state of ICAP's presence in the country? And then we'll talk about at what point did you find the level of programs to be at?
Let me share maybe before I respond to your question is something. One thing that motivated me even to come to Eswatini, in 2011 or end of 2010, I don't recall well the time, there was a team that came from Eswatini to benchmark in Rwanda. Specifically, they were interested in one program component. It was like they want to see how Rwanda is dealing with the pre-art, the people living with HIV/AIDS who knows their status, but they are not yet eligible for for treatment. And remember that time there was like
200,
200 CD4,
yeah.
So the team came to see, how Rwanda, keep that cohort of people living with HIV/AIDS who are test positive but are not yet eligible for treatment. How do you keep them, the cohort in the system, to retain them in the care? So we discussed what is happening here. And we facilitated, visiting different facilities, including how Rwanda was, implementing the program in the correctional facilities, in the prison. And I remember, especially at that time, it was like Rwanda still had, a significant number of suspected genocide perpetrators. The correctional facilities were congested, and those maybe who came with HIV or those who knew their status being already there. So that team came and learned how Rwanda was dealing with that group of patients, and we discussed it, and this was one of the element that stimulated me to come to
your connection to Eswatini. I see.
So I came. Yeah, the program was there. ICAP was supporting 3 regions of the 4 with care and treatment. It was Lubombo, Manzini, and the Hoho. And remember what we discussed in your area. You have like ICAP supporting HIV care and treatment. And you will have another partner supporting PMTCT, another partner supporting, HIV testing. You see, you will meet all in the same facilities, almost doing the same thing. This was the situation. And when I came, I was lucky because I came the time when the country was discussing the regionalization of partners. So I participated in that discussion when CDC and the other U.S. government agencies were discussing how they can better coordinate the implementing partners support in the region by having one partner by region. So this was the situation, and we started, now providing the, comprehensive HIV support, prevention, care and treatment one by region, not meeting in the same facilities. We have 3-4 partners, which was not good in terms of facilitating the work of providers at the facilities. Yeah.
I see. So I'm sure that must have been easy because you were already coming from a country that had implemented that strategy, and you had a personal experience of how well it had performed, and therefore you just had to replicate that in Eswatini. So for CDC to recommend that approach, do you know if Rwanda had informed them? Where was this regionalization approach taken from?
No, maybe, Rwanda, yes, Rwanda was doing it, but maybe also other countries. But also I want to mention that PEPFAR also, on an annual basis, there was like a meeting where they invite different implementing partners and the representative from the Ministry of Health, so that different implementing partners from different countries, they can share different innovations. So, different countries were learning from each other, and they try to replicate the same, the innovation that worked in some countries. And also, maybe from those meetings that were organized by PEPFAR, the following COP, country operating plan, will maybe try to include those success stories or innovation that have been implementing in different countries, to make sure that countries don't invent will and can apply what worked in other areas. So something that I found maybe at infancy stage, but was also bringing a significant positive change, when the structures to improve mutual engagement, like technical working group, like what they call national review of the implementation, the NASA, the RESA, the regional review of the data, and that also helped to shape the response in the country, developing again the culture of using data in planning, in response, but also using data to identify quality gap and address those gaps, based on or informed by the analyzed data.
So when you come to Eswatini, this new kid in the block. People were used to your successor, who is George, was it?
There was a lady, a colleague, I will remember the name.
So obviously...
There was Yoris, who was in interim.
Oh, Yoris,
Dr. Yoris was in interim.
Prior to...
And, the current director, who, when I came, it was like 6 months after she left, Kerry Bruce. So
you definitely have to establish trust with the people you are working with. You're in a different culture, maybe Rwanda, Burundi, they more or less share the same cultural similarities, language, French, and all of that. So now in Southern Africa. So I also want to talk about the cultural implications and how you were able to break into this culture in Eswatini. Who are the people that helped you to do that?
Thank you so much. I cannot forget. It's very important, as I mentioned. When you are new in other cultural context, it's very important that you listen, you observe, and you learn. And then you humble yourself to listen, to get advice in them. I can remember that I think in the first 2 weeks I arrived, the Ministry of Health team, the director level, and the then HIV program. I mean, not to give the right title, but I remember Dr. Okelo, who was like the care treatment coordinator, national care treatment coordinator at that time. And Madame Rejoice, who was like who's the deputy director overseeing, HIV, program. They called me and provided me with orientation, and I cannot, find the ways of, thanking them, orienting when the response, the status of the response, who is in the country, which support they are getting, how they see ICAP support, what can be improved, what I can build on, moving forward, to improve our contributions. I can tell you that orientation was, the main foundation of my integration to the new
in the country.
Success, yeah.
I see.
Yeah.
So after you get that onboarding session to keep you, to put you into speed. So what's the first thing that you're doing that you hit the ground running, taking over from what your predecessors had done?
With that orientation, which gave me, the picture from the beneficiary, the government, the host government, and the beneficiary perspective, helped me now to sit with my new team, to hear their perspective, and having that, feedback, also use it to ask a question, so that I can learn where should I focus, in terms of, support, in prioritizing ICAP support, allocating, resources. And also, of course, the support from the fund, the CDC, as well, because they are, donors perspective, expectations. Also, the CDC helped me also to get better orientation. Say, okay, yes, ICAP has been supporting, but we think you can do better if you address these gaps, these needs.
So at national level, it's very clear you have these ladies that are quickly putting you on board so that you are aware where the status of the response is. And that helps you for support in the central government. But, you have to be in the front line. There's a lot of partners you now have to work with. How did you connect with the partners, and who are these partners that you had to work with in the response as you were providing services?
Yeah, as I mentioned, ICAP was supporting 3 of the 4 regions in the countries, and then we have regional team based, not in this office, in the regions, who were working directly with, their counterpart in the region, being the regional health management team. So connecting was easy because I had a team bridging, from this office to the region and and down.
So you had teams, people from the office that were already resident in the region,
like in Ruben,
and working with the regional health management
team. Sitting so even in the same office.
The existing structure, so you just came to connect with your people, which fed you into.
Right.
Got it.
So. Yeah, the same in Manzini. Yeah.
I see. Yeah. So that must have made things easy because you didn't have to.
And also we had like on a monthly basis, the directorate that time SNAP or ENAP today, we had a monthly meeting with the director, the deputies, and then to update each other. This is where we are. This is what we are, facing as a challenge, so that we can get facilitation support from the central level, from the Ministry of Health, to make sure that we break through those those challenges. And this was also helpful because the directorate was helping. If we are facing like a challenge, maybe it's like implementation of a recently developed tool or policy, through those meetings where we update each other, we can say, oh, maybe this region is ahead because they are more receptive than this region. And then they will go back and facilitate, make just a call and say, okay, what is happening? Can you facilitate ICAP, support you and make sure that this happen? To help it fast tracking different issues, to make sure that we maximize our support.
I see.
Yeah.
So can we talk about your day-to-day interaction with PEPFAR? How do they get involved? Do you have monthly meetings with PEPFAR?
Mm-hmm.
I mean, do you have, what's the structure of your interaction coordination to keep PEPFAR informed how the response is? Because I see from the government side it's quite clear. What's the structure from PEPFAR's side for managing that?
We have what we call monthly cooperative agreement meetings. And this is where we share in detail, comprehensively updates. We share data, we share, the progress, but also we share challenges. And then we identify areas where we think that the PEPFAR team can talk to the government at a high level and make sure that that challenge can be addressed in that partnership. So, this is the most, structured, platform where we exchange, but also on daily basis, we can exchange maybe, meet calls, emails, but this monthly meeting, we sit together, we interrogate the data, we discuss, we exchange. They also provide us with updates. They think that we need to know what is happening from the side of PEPFAR, and maybe what they discussed with the government that we need to know. And they also, because they have that also discussion at that high level, they can bring feedback to say, okay, maybe you should consider looking at this issue because it has been raised by, the host government as maybe a gap that needs to be addressed. So we have that kind of interaction, which is very productive and helpful.
Can you make an example of one such issues that had to be escalated to PEPFAR to, speak with the government just to put things into perspective?
Yeah, there are multiple examples. Sometimes, it can be like, for example, like a gap in human resources. Maybe there is an activity that requires some given skills where maybe the government think that, maybe we need a support of someone either brought by as a consultant or someone to be seconded and make sure that there is a transfer of knowledge and skills to the counterpart in the government. It can be also our claim when we say that, okay, yes, we have this, like a technical advisor, but, is there like in the government institution, but we are afraid that this is maybe a second year that advisor is present in that institution, but we don't have, someone, a counterpart to transfer the knowledge and the skills too. So what happened after, that? I can give you an example. Like I remember you participated in the evaluation of the lab co-work, like lab information system. We have like LIS lab information system coordinator sitting in the Eswatini Health Laboratory system. But that position is supported by PEPFAR through ICAP. We keep reminding what happened if that support is no longer there. To make sure that our counterpart in the AHLS, they keep remembering that we need maybe to advocate for the government to hire this, or to fill this position so that services are not interrupted when ICAP support is no longer there. Yeah.
I know that also part of the day-to-day interaction with PEPFAR, there's an activity manager that gets allocated to you. So what's the level of engagement and what's the key responsibility of that person within PEPFAR?
Yeah, each project or cooperative agreement, there is an activity manager assigned to support us. And this, I can say that this is the first level of engagement with PEPFAR on daily basis. Either we need guidance, how to move with our specific support to given institution. Either it's during the planning we need maybe to agree on what should we prioritize, especially in the case of limited resources. We need advice to understand, okay, what PEPFAR or CDC as a donor think that you should prioritize this before this one. So we interact on those areas to make sure that we move with common understanding, same voice. And also another role of the activity manager is when we want to advocate for something. Maybe we, together with the supported institution, we identified a gap, but resources may be allocated to another activities, but maybe you can redirect and make sure that the other gap also can be supported, leveraging resources that were allocated to these activities. So this when the activity manager can help understand what is permissible, what is allowable, and also advocate if a redirection of resources happens, to make sure that we leverage existing resources to meet the needs.
So can you just highlight some of the key programs that were implemented during your time when ICAP was when ICAP was implementing the PEPFAR fund in Eswatini?
Yeah, I can mention that PEPFAR is the main funder of ICAP portfolio in Eswatini. Of course, there are other funding resources, but in the HIV, I can say that PEPFAR is the main one. As you know, I mentioned from 2005 to 2009, we have like the PMTCT plus program. Then we supported what we call rapid scale up of HIV care treatment in Eswatini. We supported the 3 regions, Rubombo, Manzini, and Hoho. Then this was like from 2009 to 2015. Then in 2015, 2020, we were focusing, we competed again, and we were awarded to support Manzini region. In addition to that, we have been supporting, working together with the Ministry of Health, to build capacity for epidemiology and the epidemiological surveillance and the research, capacity building, lab system strengthening. We also received some funds through HASA to support the nursing council. That this were the main, and of course we have been receiving some, small funding to support implementation science, to test some, some innovation and before the scale up. Yeah.
Let's talk more about, I think maybe the other programs are more standard in terms of like the medical interventions, scaling up care and treatment. But I want to talk about survey and research. What has been the key interventions and programs that ICAP has implemented in the country?
Yeah, ICAP Swatini was the first.
How can you not mention that?
Was the first country implementing the population-based HIV impact survey, FIA, called SHIMS in Eswatini in 2010, 2011. When I joined, by the way, ICAP, there were, the first SHIMS was, winding up. And then we are the only country that, achieved 3 consecutive field survey. So
let's talk about the decision to do the FIAs. How was that decision reached, and what we're hoping to get by conducting the FIAs? And of course, the FIAs breakdown, what that acronym is, because, the clientele of people that might not be aware. So put it at layman's language.
Now, remember I mentioned that one of the areas where PEPFAR, made a difference was like the collection and use of data for programming and informing policies. But, program data is not, alone is not sufficient, because program data, just cover, the information of those who came, the data of those who visited health facilities. Then you have a question: what is happening in the communities? What is happening with those who are not visiting health facilities? So I think that the idea of designing and implementing FIA was to cover that gap of having the picture of the epidemic, combining the program data and the data collected at population level in the community.
So FIA was one of them, and research.
And
other researches, was that the only main research?
No,
because
it
you
was
spoke
not.
about surveillance effort as well, and epidemiological surveillance. Can we talk about that?
Yeah, we as I mentioned, we received, we have been receiving funds from CDC to work with the Ministry of Health, to support the Ministry of Health to strengthen the epidemiological surveillance. We have been, developing different protocols, implementing different protocols, surveillance protocol that we implemented together with the government, including like the recency testing, COVID-19. Also, we worked with the Ministry of Health to implement COVID-19 surveillance. And in addition, also we have, other clinical research where we mainly focus on PrEP, prep C, which
I see. I know that there's also been efforts for building capacity for research generally in the country that ICAP has been involved in. Can we also talk about that?
In that effort of working with the Ministry of Health to identify the national research agenda, we also have been working directly with the research department, research and innovation department, the epidemiological surveillance unit, EDCU, and also the HRB, the research ethics board, and work with them to develop like policies, tools, and not only we're focusing on identifying research questions and develop protocol, but we worked with all those program or units to put together structures that helps to engage stakeholders in research. We had like what we call leadership group, CRG. It's a CRG. It's like a leadership group or committee to oversee what is happening in the research area in the countries and make sure that different researchers, implementing those protocols are supported, are facilitated, or provide the guidance if something maybe is going not in the right direction. Yeah. Then we have the research steering committee, but also we have like a community advisory committee, community research advisory committee. So we have all those structures that are very active, and most of them have been already, customized by the ministry. They are no longer like ICAP committees. Now they are Ministry of Health committee, and they use to support any research team or individuals in the countries to make sure that
ICAP was instrumental in the establishment through PEPFAR funding
in designing and through developing even terms of reference of those committees and the facilitation of those committees. Yeah, but doing this together with the supported government institutions, beneficiaries.
Thank you so much for elaborating on the different programs that ICAP was providing technical expertise and leadership and supporting the government, of course. I'd like to talk about more overarching issues now. Like I know the COP process was one such platform in which a lot of technical engagement was done. So please explain to me how you were involved in the COP process as a country director, as ICAP, let me just say, as an implementing partners, and how did you view that process?
I can say that the process is participatory. We, through the meetings I mentioned with the donor, in addition to that, there are like quarterly meetings where like PEPFAR brings together implementing partners, supported program in the Ministry of Health or beyond, to meet and share update. This is one of the platform, but specifically for the COP, we have a meeting with the activity managers and the project officers, where we review what have been been done and what are the remaining gaps, to give us like direction on what we focus. Of course, to make sure that also whatever we are going to propose for the new fiscal year is aligned with the strategic direction defined by PEPFAR and the host government. So from those strategic direction, we try to propose activities to make sure that we meet the needs and we fill the gaps. And there are multiple interactions with the supported institution in the government, the institution supported by ICAP, to make sure that is what we are proposing also reflect the government, strategic plan. So through those back and forth, we interact and then we align our plans. There is a lot of back and forth, which is very helpful, but because at the end, you are confident that the product you are submitting is a consensus of the beneficiaries, the donors, and the implementing partner.
So that was a process done once a year?
Every year it happened.
Mm-hmm.
Yeah.
And how long was this interaction taking place? Was it a 1 day, a week?
No. It's multiple back and forth. At the beginning of each COP, process, there will be a orientation by PEPFAR of all implementing partners together with the ministry, and especially the Ministry of Health. And also during that meeting, the kickoff meeting, they share the important date, the schedule. When the first draft should be submitted, the period for interaction, review, back and forth, and the deadline for the submission. So there is a very clear structure and the date to follow and to meet. Yeah, mm-hmm. Yeah. And this way, you ask the question about the role of activity managers. Mm-hmm. This way, you will have like support of activity managers to make sure that you move together and you meet the deadlines.
I see. So another issue that was pertinent in the way that PEPFAR was doing its program and supporting the host country, mm-hmm. was that it's not just providing resources for mm-hmm. programs, mm-hmm. but also there were other agendas that were quite important. So I'd like us to talk about the sustainability. Mm-hmm. So what was PEPFAR's aspirations as they were providing resources? Did they have foresight in terms of advising implementing partners that this is what you should do, to be cognizant of the fact that resources might not be there, mm-hmm. Forever. So what was that conversation like from PEPFAR's perspective?
Yeah,
if at all?
This way, as you know, sustainability, it's an issue with different multiple dimensions. Mm-hmm. There is a financial sustainability, but also there is, sustainability from programmatic perspective. PEPFAR and the government, they have been facilitating interaction of different partners and the supporting institution to think through about sustainability. And the process, if I can describe, was like mainly, let's see, what can survive without, current support. Now I'm talking about maybe not only financial sustainability, but also, as I mentioned some areas like LIS, where you need informatics team to maintain, to troubleshoot, or other data system, like client management information system, it's not just a matter of having like resources to renew license, yeah, to renew license, of LIS, but do you have informatics skills to maintain and troubleshoot if there is any LIS issue rising? We had like those kind of discussions and make analysis. Where are we now? What are the threats? Because you have to see, okay, maybe like for Eswatini, the good thing, like Eswatini has been since the beginning of the response. For example, the government buy drugs and maybe some supplies, but there are other maybe issues pertaining to supply chain that may require more investment to make sure that service can continue. There are not interruption or shortage of commodities. So we have been, with the facilitation of the government and the PEPFAR, we have been having as a stakeholders those kind of discussion to see what will happen for this technical domain or areas. Where are we to feel confident that if today the support is cut in terms of finance, but also technical support, can the country sustain the service in that areas? Mm-hmm. So that discussion has been happening, and they're trying maybe to identify what are the areas where the domestic funding, for example, should start, maybe putting more resources, and while maybe PEPFAR and the other donors like Global Fund and the others are maybe reducing the funding.
I see. So is this a document that has been developed that encapsulates that kind of a discussion, or it's just an agenda, standing agenda that keeps on featuring in when you have your conversations with the host government?
I cannot say that I sold the final product, but it has been documented, details and inputs given by different partners. But I'm still, as I mentioned, I didn't see yet the final document or product from those discussions. But it's something that have been happening for some months.
So who's the custodian of this documentation? Is it, the host government? Is it was it PEPFAR? Is it ICAP?
No. The PEPFAR made sure that, yes, PEPFAR can help to bring together, support the implementing partners, but in the all introduction of those discussion exercise, PEPFAR had been mentioning that this is a government exercise. It has to be led by the government. So there were like a focal person identified from different program in the Ministry of Health, to lead the exercise, but working with stakeholders and the PEPFAR. But there are people leading from the Ministry of Health leading this exercise. Not only, by the way, not only from the Ministry of Health. I saw even people from other ministries that were participating in this discussion.
I see. So one other thing that we've come to learn was that PEPFAR's thinking about sustainability included transitioning plans in terms of programs. So are you aware of those plans, and if so, what were they, and how, as ICAP, you were able to incorporate that thought pattern, in terms of how you're doing your programming?
Yeah, we have been discussing with like CDC since every year we see, okay, we are planning for the next year what do you think should be transitioned to the government? We identify, even among the position like being supported, we say, okay, we think that this position can now be transitioned to the Ministry of Health. We think that this cost should be also transitioned to the Ministry of Health. I gave like an example, concrete example, when we have been like a LIS license. Every year we need to pay license, but I think the Ministry of Health, started already absorbing that cost. And there also other there are some facilities like we have been supporting that can also say I know I think it's a RFM, Baylor, they say, oh yeah, you support us in the HF, you support us for maybe 1-2 years, then after the 2 years we absorb that cost ourselves. And what we do for the position, for some operation cost or some trainings, we'll write it to the Ministry of Health as we agreed upon on this transition process. These are the positions that from now will be transitioned to the Ministry of Health. These are operation costs that will be transitioned to the Ministry of Health moving forward.
I see. So in terms of not just maybe HR and operational transitioning, programmatically, what did it entail? Was there a different way that was now proposed to prepare for transitioning in terms of how program and service delivery was done?
Yeah. Again, nothing happens automatically because you may feel like goodwill of the Ministry of Health, to absorb that cost, but maybe there is the financial constraint become like you agreed maybe it happened once, but it doesn't happen the next year. You have to come back again, for hiring, absorbing position. That for some years the recruitment or hiring by the government, was frozen. So you cannot do more with that situation, even though that maybe the willing was there that, okay, HS or any other program says next year I will advocate for absorbing this position in my my staffing plan. From programmatic, there are also some areas where you say, accreditation process. There are different steps, assessment, making sure that that everything is assessed to make sure that the facility that is a candidate for accreditation meet all standards required for the accreditation. There are, in those process, you can see, this can be led easily, handled by the supported, institution, just to give an example. Even in the programmatic areas, there are some activities or some trainings where you don't need to bring, outsiders to come to train. When people have been skilled, they can, provide that training easily and competently, without an external support.
Okay, as we wrap up in terms of programs and the role of ICAP to really contribute towards the success of the HIV response in the country has been, what would you say has been the greatest transformation that has occurred in Eswatini through ICAP's leadership and support from PEPFAR, of course?
Okay, I can name, but again, I want to make an initial disclaimer. nothing can happen without a true and transparent partnership. For me, this was the pillar of the success of ICAP contribution to Eswatini. It's the partnership, the true partnership with the Ministry of Health, other institutions in the government that were supported by ICAP, like CSO, for the survey we were talking about, the impact, assessment, and the others. One of the success story I can mention is like system put in place for data collections. It's also system put in place for mutual and stakeholders mutual engagement. Remember what I mentioned, like the different committees. Of course, there were like in the kind of treatment, there were those technical working group, but like in the surveillance and the research, there were also structures that were put in place and supported, facilitated, when absorbed or now, owned by the Ministry of Health fully. The same in the lab system, we have like lab technical working group, which is very functional, group, and that also is a strong platform to bring, different contribution ideas, new ideas, contribution of different stakeholders supporting the health system, the lab system strengthening.
Okay, so I know that you're not working really a lot on prevention per se, because you started from testing, care, and treatment. But I don't know, did you feel that indigenous knowledge systems were impacting the work that you were doing? Like, for instance, how it affected uptake of or non-uptake of testing, how it affected, scaling up of care and treatment and retention in care. Would you say that indigenous knowledge systems had an impact in what you were doing, or competing, or sometimes, posing as a challenge?
We worked in prevention really, maybe until we were more in that area until 2020. We worked in the male circumcision, which was an intervention that showed can show impact in prevention. We talked about PrEP.
Yeah.
But also when we were in the kind treatment partnership, we supported the PMTCT. And I can say, when you see the level of uptake and the literacy, we can say that, the indigenous knowledge improved significantly. Among the survey, I remember there is, beside the fear, we also implemented the violence against children survey. And I saw that how not only ICAP, other partners came in to use the data to develop key messaging, to address the issue of violence. This is where you see that, the effort of the Ministry of Health, to improve indigenous knowledge in terms of prevention also increased, but also the receptivity and those messages. You can feel that that area has been improved because of different effort. I'm not saying that everything is perfect. There's still room, like PrEP. There's the room, to improve. Like there may be knowledge that the services are available, but what is the coverage? Is what I mean. The same male circumcision. remember that even when we were providing support also in male circumcision, because we were leveraging the resources we have in care and treatment to support male circumcision, the coverage was still low. Yeah. The knowledge may be there, but now how that knowledge is translated in a practice, but also in a services utilization by the population. Yeah.
So I want to talk about more interpersonal kind of issues and cultural consideration that contribute into how programs are run. I know that there was a time, I think I've heard this quite a bit around when Ambassador Birx was the one who was holding the reins of PEPFAR. There was really a lot of a drive for data being available and that used as evidence for changing programs. So during that time, there was really pressure, if I may say, for host government to do things in a particular way that were not necessary. So how were you able to put through that expectation within the government, because that was a definitely shift and a different way of doing things? What can you say about those kind of expectations and you being caught in the middle to make sure that the pressure that's coming, it goes to the host government, but you are very tactical in terms of how it does not spoil relations? So, I mean,
let me tell you my point of view. That was necessary pressure. And I'm convinced that, different governments, different countries are now, getting fruit, from that
pressure.
It was, pressure. Sometimes it's a common human being, how to say, resistance to change until maybe there is an exercised pressure. The change won't come in the right time. That pressure to collect quality data, to inform the progress, to monitor the epidemic was very necessary. Was very helpful for countries, and this you can feel now that countries, it helped the countries collecting quality data, analyzing data to see how we are moving, help the country to say, oh, hey, I'm not doing well with the first 19, for example. We may think that, the suppression is good, or you don't know if, you keep, giving medication, drugs, but you don't know, is this drug working, responding. So I think that I don't, from my personal perspective, I keep telling people that era, or of that so-called pressure to report on target, brought like two major, positive, how to say, outcomes. One is it enforced accountability, linking resources, allocated resources to the result. Because otherwise, in the previous you receive maybe funds, but there is not that tight link that, what was the impact of this US dollar that was put in this activity. And the second, it helped the countries to say, oh, we thought that we are doing well, but we are not. You see, it was like an instrument, or an element that helped to wake up different programs to say, hey, we have been putting resources mainly in this area, why maybe this gap, if it is addressed, it will make more impact on the epidemic control than if you keep just pumping resources in this intervention, that may bring just small small impact to the epidemic control.
I see.
Yeah.
We know that DREAMS was one of very important programs that PEPFAR supported in the country. Were you involved in any way in the implementation?
Not directly, because we are not, but yeah, we
in the larger scheme of things.
Because we are supporting lab systems, strengthening also it's important for for DREAM.
Okay, so PEPFAR became a very important and powerful driver for the HIV response in these latter years, because of the funding they have, the amount of resources they had. So, from different quarters, there is that discourse which says, that kind of resource gives a lot of muscle and power to PEPFAR, to the US, to steer local, governments and shaping what the priorities are. So I want to find out from your experience, when there are these issues on the table that needs to be discussed and there are these negotiations taking place, how did you find the power? Was it balanced, imbalanced? How was this navigated? This is purely subjective in terms of your observations. The directorate engaging with PEPFAR when there are contentious issues or conflicts. Did you find that the government had equal power on the table, or there was a lot of imbalance?
Let me talk.
Of course.
At country level, what I'm seeing.
Yeah.
I may not be when positioned to maybe to make the
I do
global
actually
analysis.
mean that you talk about the country level.
I can say that the engagement, PEPFAR, government, and the implementing partners was very, respectful, and transparent. Say, okay, this is what it is. Let's see how to, to align with, what is expected at a, global level. So I really appreciate, because we have been invited in the meeting to be updated, regularly updated, like at least once a month. We are invited. We implementing partners, the government, institutions supported by PEPFAR. We have been invited for regular update by PEPFAR of what is happening at a global level, in the Washington administration, and also making sure that we are complying. We are knowledgeable of what is the policy, what is required, and make sure that whatever we do, we are in compliance, so that we don't jeopardize, our work and funding. So I can say that, there is a respectful. Now balancing the powers. For me, if there is this transparency in updating each other, being transparent, this is what is required, this is what is happening, this is what we are required to do, and it being done in a respectful way. I can say that at country level, it's balanced. Yeah. Yeah.
Okay, so there's just a little bit of a follow-up I want to ask about sustainability strategy. I know that most of your strategy for transitioning to the government relates to absorption of positions and allowing government to take the leadership role for some of the operations and investments that ICAP has helped to establish. So, now we see that there's a lot of transformation that's taking place in the global aid space. So how is ICAP planning to maintain its operations, until such time whereby I think the transition is fully taken effect? Do you have any plan, like, to continue operations should I mean, as we see that things are volatile and rapidly changing.
And it's a good question. You know, as I mentioned, sustainability has multiple dimensions, and one of the key dimensions is funding. We in this period, we try to make sure that we operate as much, efficiently as much as we can. Yeah, to make sure that we operate, maximizing the efficiencies and make sure that yes, there may be many things, good things to do, but we have to do what is necessary. We keep also discussing with CDC, with the donor, to help us to better understand how we shape the little maybe resources may remain, and how to allocate efficiently, and make sure that also we meet our obligations, our contractual obligations, because to operate like in a country as international organization, you need the rent, you need staff, you need internet, you need all those and different considerations we have to make, and keep discussing transparently with the government, with the donor, to see how far can we go. Yeah, so I may not give you the right answer, but I'm just sharing what we, which approach we are following, and what are we considering in making sure that we can sustain our operation in the country.
So the recent operations that are continuing through the limited waiver. For life saving.
For life saving, but in addition to, we have like some other funding for for non-HIV portfolio.
I see.
Or some small funding for non-PEPFAR funding, that we also trying to leverage and make sure
spread
that
around and use efficient as much as possible. How has working for PEPFAR impacted you personally and professionally?
No, it was a privilege and the honor to be part of this big global initiative that made difference in many countries. To tell you the truth, I told you PEPFAR came when a system and I can say wounds, like in Rwanda, they are still fresh. Everything was corrupt. The country should focus on other things to make sure that the country can again be resuscitated, how to call it,
to
recover from the genocide, the genocide. And I had that privilege of following the path of PEPFAR support and be among the privileged witness of the impact, in terms of, I remember how like the infrastructure, even, like health facilities when, in poor status, no lab equipment, no skills to do, to provide, quality services. But, you can see that, PEPFAR contributed a lot in improving system of health services provision, rehabilitating, renovating infrastructure, putting system for efficient management of commodities, all those changes or revolution in the system. This is what we can be proud of as people who were part of that effort.
Thank you.
Yeah, thank you.
Is there anything that you'd like to add? Like what can be done differently? People misunderstanding PEPFAR, whose voices are missing, as we are trying to preserve the history and the legacy of PEPFAR. I mean, do you think there's an aspect that we need to incorporate to make sure that we provide a comprehensive picture of what PEPFAR was, what it did?
No, this is a good question. As we mentioned, yeah, PEPFAR was like emergency response, and then maybe was operating as a emergency program, making sure that services are available, skills to provide services are available in the country, but also, we saw like the transformation in the system, in the building blocks of the health system, how they improved because of leveraging what is happening with PEPFAR support. And also, we saw with PEPFAR different models that have been implemented, how people living with HIV were not, as I mentioned, not just passive recipient. The engagement of recipient of care, the engagement of the community families, became like a model, across PEPFAR programs. Now, I think from even the lesson of the changes that are happening, today, focusing on life-saving activities, I think PEPFAR maybe can come up with a model how to accompany countries, because like countries in the sub-Saharan, region, they don't have the same potential, economic potential, the same technical capacities. Maybe how to accompany them, to plan for, how we call it, a responsible exit or transition. So I think different countries need that support, to help them, think through like what we were saying, the sustainability discussion. How can you accompany them, to do it in
provide the
guidance. Yeah, so that
to see how they can effectively put sustainability.
Otherwise, you see, countries, they thought that, PEPFAR will continue maybe to support. There is no eternal, program. This thinking should have started a long time.
Yeah.
Countries think, how can I absorb gradually some cost and include in the, ordinary budget for domestic fund. One country cannot take the responsibilities of the whole world. This is my personal, opinion. Yeah.
Thank you so much, Dr.
Thank you.
Ruben.
Thank you.
It has been a pleasure to listen to your experience and your valuable insight in terms of how you personally have contributed to shape what PEPFAR is doing, as well as working in partnership with the different host countries. And we appreciate the efforts and the time and passion that you have extended to make sure that the success of PEPFAR to hold HIV infections globally has done, especially for the countries where you've worked. So that brings us to the end of our interview. Thank you so much for your time.
Thank you for considering me to give my just a humble, contribution and thinking and thought on this. Thank you.